Some people have proposed that you can actually do a second trimester uterine artery Doppler as a screening test for PIH and preeclampsia. Now the thing is, this has gone through a lot of debate and controversy. They found in low-risk pregnancies it's really not of value screening for PIH. In high-risk pregnancies, it has value in the sense like if the uterine artery Doppler is abnormal in the second trimester in a patient who has had a previous PIH, then the chances that she will have PIH again in this pregnancy increases 7-fold. But if the uterine artery Doppler is normal, then the negative predictive value is very high. She is she is less likely to have PIH during this pregnancy, which may actually be reassuring for the patient. So that is something we should take, and they are also trying to shift the preeclampsia screening for the first trimester by a combination of uterine artery Doppler and pregnancy-associated plasma protein A. Now, of course, new molecules are also coming into the picture. Then, in some patients, majority of the patients, the fetal heart can be seen very effectively between 18 to 20 weeks. But in some patients where the penetration is poor, or the baby is not lying in good position, or the liquor is not adequate, then you may want to ask the patient to come back at 22 weeks for a detailed fetal echo. Now, between 30 and 32 weeks, that is, we call this as a growth scan, because by this time most of the growth disorders are manifest. Because after 28 weeks we find your asymmetric IUGR, everything is already seen in the abdominal circumference, and you have a very efficient way of picking it up. And the best way, of course, is to plot a growth curve. The moment you look at this growth curve, you say this baby is not growing all right. I have no other information about this baby. I have not told you what the BPD is, abdominal circumference is. But the moment you see the graph, you see it is falling off the normal graph, you say this baby has got IUGR, or this baby's growth is not all right. So that's the power of the growth curve, which everyone should do. You can simply take a curve and you can plot it on your own. If you don't have a computerized system, you can actually plot it manually. And these growth curves are available on our website for you to download. Simply print it out and start using it. Then the third trimester scan can also be used for assessment of fetal well-being. When we talk about fetal well-being, we are talking about fetal activity, and we are talking about the liquor and the placenta. Now these are three things which are going to help you to assess fetal well-being. A combination of Doppler in selected cases. In third trimester, there is no indication for doing routine Doppler. We do Doppler only when the abdominal circumference falls below the percentile, or when there is liquor, liquor is reduced. We want to know whether it's placental related or not placental related. That's when we do Doppler. And in cases of, for example, you're suspecting RH isomerization anemia, then there's an indication for Doppler. Otherwise, a baby which is growing well, which is moving well, which has got normal liquor, absolutely there is no indication for Doppler in the third trimester. So we need to use the modality very, very judiciously in patients who require that information. Otherwise, we end up by having different interpretations of Doppler, difficulty in decision making, so on and so forth. So now, after 32 weeks, it's a matter of fetal surveillance. You'll find some patients will require frequent monitoring. The idea, of course, is want to deliver the baby at the appropriate time. For example, if there's an IUGR baby, then we would monitor the baby much more closely as compared to a baby with normal growth and liquor, where we'll say, okay, let her go through the routine course, and you tell the patient to come for your routine antenatal checkup. So the decision to actually do further scans in the pregnancy after 32 weeks is entirely individualized according to the patient's need and the decisions you want to make according to that. So having given this sort of broad framework of how you can take the patient through scan, in fact, when the patient first reports to you in early pregnancy, you might actually want to put a calendar for this patient, saying these are the investigations I'll do at this point of time, and these dates are prefixed. When you prefix the dates, then the patient is not taken by surprise. Tell her these are all routine things, because she need not get anxious about going through a scan all the time. So now let's talk about early pregnancy. Now in early pregnancy, we are talking about confirmation of pregnancy. Well, even though confirmation can be done by a urine pregnancy test,